Discover the 2 crucial safety checks you must make before choosing a 4th antihypertensive agent. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 20-year-old woman is seen in the nephrology clinic for routine follow-up of long-standing resistant hypertension. 3 years ago, angiography demonstrated multifocal fibromuscular dysplasia of the right renal artery that was treated with percutaneous angioplasty, but home blood pressure logs have remained in the 150s over 90s millimeters of mercury. Her current antihypertensive regimen at maximally tolerated doses is lisinopril 40 mg once daily, amlodipine 10 mg once daily, and chlorthalidone 25 mg once daily. She also takes allopurinol 300 mg once daily for gout, colchicine 0.6 mg as needed for flares, sertraline 100 mg once daily for depression, and vitamin D 1,000 international units daily. She denies nonsteroidal anti-inflammatory drug use, licorice, and over-the-counter supplements. At today's visit, she feels well. After 5 minutes of seated rest, temperature is 36.8 degrees Celsius, pulse 88 per minute, respirations 14 per minute, blood pressure 152 over 96 millimeters of mercury, oxygen saturation 98% on room air, and body mass index 31 kilograms per square meter. Cardiopulmonary and neurologic examinations are unremarkable. There is 1+ bilateral ankle edema. Laboratory studies obtained this morning show sodium 139 millimoles per liter, potassium 5.3 millimoles per liter, creatinine 1.9 milligrams per deciliter, blood urea nitrogen 30 milligrams per deciliter, uric acid 9.8 milligrams per deciliter, calcium 9.1 milligrams per deciliter, hemoglobin 13.4 grams per deciliter, platelets 248 times 10 to the 9th per liter, leukocytes 6.7 times 10 to the 9th per liter, urine albumin to creatinine ratio 310 milligrams per gram, plasma aldosterone 4 nanograms per deciliter, and plasma renin activity 1.4 nanograms per milliliter per hour, measured while she remains on lisinopril. The nephrologist plans to add a 4th antihypertensive agent. Which of the following medications should be avoided because of a specific contraindication or major precaution in this patient? Option A. Add eplerenone 50 mg orally twice daily for resistant hypertension. Option B. Switch chlorthalidone to furosemide 20 mg orally twice daily now. Option C. Add hydralazine 25 mg orally 3 times daily with meals. Option D. Add clonidine transdermal 0.1 mg daily, replaced weekly for hypertension. The correct answer is Option A. Add eplerenone 50 mg orally twice daily for resistant hypertension. The medication that should be avoided is eplerenone. This patient has several strong reasons not to start a mineralocorticoid receptor antagonist. Potassium 5.3 millimoles per liter, creatinine 1.9 milligrams per deciliter, ongoing lisinopril therapy, and albuminuria. She also already has a history of renovascular disease treated with angioplasty, so preserving renal safety matters. Adding eplerenone in the setting of baseline hyperkalemia and impaired kidney function would create a substantial risk of dangerous further potassium elevation. In practical terms, the problem is not whether eplerenone can lower blood pressure. It is that the patient has a clear safety signal against using it. The other options are not ideal first choices, but they are not the one with the specific contraindication or major precaution highlighted by the stem. A clonidine transdermal patch may cause sedation or rebound hypertension if stopped abruptly, but baseline laboratory studies do not make it specifically contraindicated. Hydralazine is a later-line vasodilator and may cause reflex tachycardia or fluid retention, yet it is not specifically ruled out by this patient's potassium and creatinine. Switching chlorthalidone to furosemide may be considered when kidney function declines or edema becomes more prominent, so it is not the clearly contraindicated step either. In summary, the correct answer is to avoid eplerenone. Primary teaching point: never add a mineralocorticoid receptor antagonist reflexively without checking baseline potassium and kidney function. Secondary teaching point: in resistant hypertension, the best drug mechanistically may still be the wrong drug when safety thresholds are crossed. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.